Next, we're going to talk about the GI system. Adequately hydrated infants have pink and moist mucous membranes. Their hard and soft palates are intact. Some babies can be born with what's called Epstein pearls, which are small white spots on the gum, and that's normal. Sucking begins in utero between 15 and 16 weeks. Intestines are sterile at birth, so there's no bacteria in the intestines at birth. Stomach capacity varies from 30 milliliters on day 1 of life to 90 milliliters on day 3 of life, so that's 1 ounce, basically 1 ounce per day of life. Natal teeth. Babies can be born with what's called natal teeth, and they're just little bitty baby teeth that are already through the gums, but they are poorly formed roots, and they may be aspirated, so it's really not good for babies to be born with natal teeth, but it's something as a nurse you would be able to recognize and teach the parents and notify the caregiver, the provider. Vowel sounds are heard shortly after birth. For digestion, newborns have enzymes to digest simple carbs and proteins, but they have a limited ability to digest fats. Stools. Meconium is thick, green, black stool, and it contains occult blood. It's formed in utero of amniotic fluid, intestinal secretions, and cells. The first stool is sterile because the bowel is sterile. And most pass meconium by 12 to 24 hours of life, and almost all by 48 hours. But the first passage of meconium is usually by 12 to 24 hours. On page 531, there's box 23-1 that shows us the change in stool from meconium to transitional stools to mixed stools, and you'll want to make yourself familiar with that. Feeding behaviors. Typical feeding behaviors include a hand-to-mouth and then sucking on fingers. Infants do this. That indicates they're hungry. You want to feed babies when they start exhibiting these behaviors rather than waiting until they're just starving and screaming, especially if they're breastfeeding. It's very difficult to latch a baby that has reached the point of beyond hunger. Signs of GI problems include failure to pass meconium, and this can indicate bowel obstruction. Abdominal distension at birth can be a ruptured viscus or a tumor in the abdomen. As the nurse, you want to note the time, color, and character of the infant's first stool. Abdominal distension can be caused by overfeeding. Infant diarrhea is defined as forceful ejection of stool and a water ring in the diaper around the stool, so you have to be able to differentiate infant diarrhea from the normal changes in the stooling pattern. So the diarrhea is this forceful ejection of stool, and in the diaper there'll be a water ring around it, so your baby can get dehydrated very quickly. Projectile vomiting can be a sign of anomalies, such as caloric stenosis or an intestinal obstruction. And you can decrease vomiting by not overfeeding, burping babies frequently, and keeping them in a slightly elevated position. So whether you're the nurse feeding the baby or you're teaching new parents how to feed their baby. The next system is the hepatic system. The liver can be palpated 1 to 2 centimeters below the right costal margin. First, we're going to talk about iron storage at birth. The term infant has an iron store sufficient to last 4 to 6 weeks. Breastfeeding infants need iron supplementation beginning at 4 months. Let me go back and talk about the iron stores at birth. Term infants have an iron store sufficient to last 4 to 6 months, not 4 to 6 weeks, 4 to 6 months. Breastfeeding infants need iron supplementation beginning at around 4 months. until they start eating foods that contain iron. Infant babies that are bottle feeding don't need additional iron because infant formula contains enough iron. Carbohydrate metabolism in utero. Glucose concentration in the umbilical vein is approximately 80% of the maternal levels, so we know that when the cord is cut, that the glucose that's coming from mom to baby is stopped, and we talked about that being important when a mother is diabetic and has especially uncontrolled diabetes, that the infant is used to producing a lot of insulin, and then once you cut off their glucose stores, they can get hypoglycemic pretty easily. Glucose levels reach the lowest level between 30 and 90 minutes after birth. So if you wonder when a baby is most likely to become hypoglycemic, it's 30 to 90 minutes after birth. Feeding helps stabilize newborn blood glucose levels, so that's your first intervention, is to feed them. Less than 40 milligrams per deciliter is abnormal and requires intervention. So 40 is kind of the cutoff. Signs and symptoms of neonatal hypoglycemia include jitteriness, lethargy, apnea, feeding problems, seizures, or they may be completely asymptomatic. To correct the hypoglycemia, you first want to start out with feeding, and if that doesn't help or the baby's unable to eat for whatever reason, they may have to get IV glucose. Next, we're going to talk about jaundice. Jaundice is the visibly yellow color of the skin and the eyes. It's caused by elevated serum levels of unconjugated, which is considered indirect bilirubin. So, jaundice is caused by elevated unconjugated bilirubin. The liver is responsible for the conjugation of bilirubin, which results from the breakdown of red blood cells. And if you go back to that graph we talked about a couple of slides ago, the liver is responsible for the conjugation of bilirubin from that fat-soluble unconjugated to the water-soluble conjugated. Unconjugated bilirubin must be broke down into conjugated bilirubin to be excreted through the feces and urine. Feeding is important to decrease the bilirubin and increase excretion. So, jaundice babies, feeding is very important. Frequent feeding and making sure they're getting enough and making sure they're passing stool. Jaundice occurs when the levels of unconjugated bilirubin exceed the ability of the liver to conjugate it. So the breakdown of the red blood cells causes the bilirubin, and the liver normally breaks that down, and once the level of bilirubin exceeds the ability of the liver to conjugate it or break down that unconjugated bilirubin, then jaundice occurs. Jaundice is first noticeable in the head and progresses to the thorax, abdomen, and extremities. So basically, if you have a baby that's jaundiced all over their body, they're extremely jaundiced. If they're just jaundiced in their head and their face, they're less jaundiced. Prematurity is the most significant factor to increase the risk for hyperbilirubinemia. So now we're going to talk about the different types of jaundice. Physiologic jaundice occurs in 60% of term and 80% of preterm infants, and it appears after 24 hours. It usually resolves without treatment. The bilirubin levels increase to 5 to 6 milligrams per deciliter by 72 to 96 hours of life, and then decrease to 2 to 3 milligrams per deciliter by the 5th day of life. And then from there it just gradually decreases to normal by 2 weeks. So physiologic jaundice, 80% of preterm infants and 60% of term infants experience this type of physiologic jaundice, and so we would basically say that that's normal. So then we'll get into the abnormal, which would be the pathologic jaundice, and this is where the unconjugated hyperbilirubinemia is either pathologic or severe enough to need treatment. So if the physiologic jaundice progresses to pathologic jaundice, it's become severe enough that it needs to be treated. It's considered pathologic if it appears within 24 hours after birth, so that's a difference compared to the physiologic, which occurs 24 hours after birth. Pathologic jaundice is considered pathologic if it appears within 24 hours of birth. So baby 0 hours to 24 hours. And physiologic is the baby is greater than 24 hours. The total serum increases to 6 milligrams per deciliter by 24 hours of age, or exceeds 15 milligrams per deciliter at any time. And that's where it goes back to if it started out physiologic but increased great enough over 15 to need treatment, it's become pathologic. Hemolytic diseases of the newborn caused by maternal newborn blood group incompatibility is the most common cause. So maternal newborn blood group incompatibility is the most common cause. Also, G6PD deficiency in Asian or Native American infants, bruising, cephalohematoma, delayed cord clamping. There's a table on page 23-3 on page 533 of your book, but those are the main causes of pathologic jaundice. If it progresses, it's very neurotoxic, so it's toxic to the brain. You can get acute bilirubin encephalopathy, which is the bilirubin toxicity. So the signs and symptoms are lethargy, hypotonia, irritability, seizures, coma, and even death. So it's very important to monitor the level of jaundice based on the hours of age, so it doesn't become neurotoxic. So kernicterus is basically the worst form of bilirubin encephalopathy, and it's irreversible long-term consequences of bilirubin toxicity. So these kids are very mentally delayed and usually total care, and it's basically very sad to think that it was 100% preventable just by monitoring and intervening for jaundice. There are two forms of breastfeeding-related jaundice. So what this means is breastfeeding doesn't cause the jaundice, it's the lack of effective breastfeeding that contributes to the hyperbilirubinemia. So first is the early onset, or the breastfeeding-associated jaundice. This begins at 2 to 5 days of age. It's caused by lack of breast milk, so here the baby is just not getting enough to eat, so they have less caloric and fluid intake and fewer stools. The bilirubin is then reabsorbed from the intestines back into the bloodstream, so basically the baby's not getting enough fluid and calories and fat to be able to pass out the bilirubin. The second is late onset, which is also known as breast milk jaundice. This occurs at 5 to 10 days of age. This baby is feeding well and gaining weight, but the bilirubin peaks at 2 weeks of age and then gradually decreases. It can persist from 3 to 12 weeks. The etiology is unknown, but it's related to factors in the breast milk. So early onset is a result of lack of breast milk, and late onset is caused by something in the breast milk. Treatment for both is to keep feeding as much as you can. You don't stop feeding because of these.